Thank you, Mickey. I appreciate that. So let me back up here since I have wonderful people going over things. Um, we'll start here, so I'm not gonna go over the whole part. Please make sure you read your emails and the Facebook page for the ones that obviously I was not recording earlier. So thank you to Mickey. I appreciate that. All right, so over this, we're gonna talk about those as we go further. What we can and can't do, how we treat it, what we do to them to make them a little bit better in the beginning and to the end. All right, here. So the pathophysiology assessment and management. We're going to talk about wounds. We're going to talk about avulsions. Those are nasty. Bite wounds, human and animal. Which ones? They both gross, but I'm going to let y'all figure that out when we get closer to it. You'll have lacerations, punctures, and incisions. No, when we're talking about incisions, there can be from a surgery that has sutures, and maybe they've had an avulsion from that. So we'll dive off into that a little bit deeper we go, but that's kind of the basis of where we're at. Sorry, I'm diving off over here in my own brain. Pathophysio. Also, we're going to talk about those. Crushing syndromes, pretty big one, which you're going to see. Under electrical, there's the four types: electrical, chemical, thermal, and radiation. That goes underneath the burns. It goes in depth. I kind of hate talking about this early, so we kind of fly through this as fast as I can. I'll say, here we go. So soft tissue injuries are common. They can be simple as a cut, a scrape. You can't walk straight. You fall on the concrete. Uh, just don't be too distracted on it. Just because it's an open wound, just don't neglect other life threatenings because this one's like, oh my god, that's gross. Geez, did you see their knees? Well, maybe did you see their eye that's hanging out that you can't move past their knees because they're right there at you. So just because that's the first thing you see and or they bleed a lot or just keep going on with your assessment. Soft tissues of the body can be injured through various mechanisms. A blunt injury occurs while the energy exchange between the patient and the object is more than the tissue can tolerate. So let's see here. So if we hit you with a pencil, the skin can tolerate that. We step it up, we go to a wooden spatula. You can handle that too. Depends on what part of the body you're hitting. The bigger the object is what makes the skin split. Um, that can be your penetrating trauma. It can be blunt injury. Sure, it's not going to cause a burn by just striking you with an object, but um, a penetrating injury occurs when the object breaks through the skin and enters the body. Kind of hints penetrating. I think you're already aware of that. Barotrauma, commonly seen in blast injury victims, refers to injuries that result from a sudden or extreme change in air pressure. So I'm sure all of y'all have seen all the videos from the military. Thank God that they're there and they have the videos so we can grow from it. What about the explosions? That has taught us more than what we want to know in the medical is growing and just learning how to treat those. So that has been another thing that's helped us out for that is videos really. You also get the burns that were related to these soft tissues. It can be from the barotrauma. It can be potentially from a penetrating trauma. Depends on if let's say a hot rod is stabbed through the arm or the leg. You may have some. It may seal everything off because it's been burned on the inside. But we'll treat about those and go forth through there. Introduction. Open wounds accounted for approximately 4.1 million ED visits in 2011. Yeah, that's an old number, but think about that. That's 10 years. Imagine what it is, and that was just 4.1 million injuries 10 years ago. Football. Can you imagine what that number? I guarantee it's way higher. Wound care is the most frequently performed procedures in the ED across the United States. You just be sympathetic, wipe it off, put a band-aid on there. Hold on 2 seconds and make sure my son's not injured or upset. Hang on. All right, for y'all, the ones that know the kids that drive, it kind of makes you nervous when they call you and they're not home. So that's what I just making sure everything's good. All right. So most of these injuries require basic interventions. We're not asking you to start IVs on them. We're not asking you to be like, oh, we're going to put a tourniquet on that. This is just basic, common core stuff that you've learned throughout your life. Okay. So wound irrigation, y'all know, even when you get something home, oh, we need to wash it out so it didn't cause an infection. You want to dress it right. You want to bandage it correctly, and limited suturing. Now, I'm pretty sure you guys aren't going to be doing some suturing. We do suture offshore. We do have the ability to do that, depending on the size of the cut, length of the cut, and the depth. So we do have that ability off there. When the skin barrier is breached, invading pathogens can cause local or systemic infection. We don't want it dirty. We want to clean it. We want to make sure that it's in a lot better spot once they close it. Because yes, they're going to irrigate it some more. They're going to wash it out and move forward. But if we can help do that, that's the last time that that infection is potentially going to be inside the body. Okay. Um, an infection can be life or limb threatening, especially in children, older adults, and people with diabetes or other conditions that may compromise the immune system. Soft tissue injuries and their complicates can often be prevented by using simple protective actions. Let's see here. Effective strategies to reduce injury and death from burns, smoke alarms, controlling the temperature of a hot water heater, and enforcing building codes that regulate electrical and construction practices. So, with that being said, is what we can do is we can prevent this. We just small, simple things that we can do. Make sure when you get a new thermostat installed, I mean, a water heater installed, the plumber is going to ask you, how hot do you want this? Whatever it came with. Well, that might be 178, 200 degrees. Not what we won't, unless y'all really like those hot showers. Y'all can do that on your own, but that's not. So simple things like that. The burns. You want to install your smoke detectors. Hope everybody knows anytime that the clocks change, as in fall forwards or backwards, we gotta change the batteries in those things. So think about that. Remember those simple things, all right? All right. The anatomy and physiology of the skin. The skin is the body's first line of defense against external forces of infection. Well, thank God. It's also the biggest organ that is out there. I don't know if y'all know that. It is the largest organ, like I said. It is relatively tough, but still susceptible to injury. That's how you get your paper cuts and your little knuckles busted. So we know it's constantly growing. Um, Stand by. I just want to double check. All right, we're good. Gotta get back on my chat box so I can see everybody. Well, get back here. All right, so gotta find my mouse. I'm moving two screens, so that's where it screws me up. Injuries range. Injuries may be exposed blood vessels, nerve, or bones. Depends on the depth. I mean, it could be, an open fracture. It could be a closed fracture with, the skin's broken or the skin's poking through the skin. It could be a cut with you exposing bones. So when you see that, after you gain your composure and you move forward and you're not like, oh, that's gross. I can't see it. So remember what you got to do: clean it, stabilize it, move forward. In all instances, the EMT must control the bleeding because if we don't, we're not going to have a patient no more. We got to fix that because if you don't stop it, it's going to cause you to start doing CPR, but then there's no blood to go round and round. It's going to carry oxygenated blood and deoxygenate it away from the body. So just stop it when you see it. That's a priority. That's a major thing. Apply dressing and bandages to various parts of the patient's body. If you need to, apply the multiple 4x4s and hold them down with your palm of your hand or the gloved palm of your hand. There's the yawn. Until you get Kerlex or trauma dressings or anything like that. That's okay. That's cool to do. So remember that. Oh, skin varies in thickness. Depends on the location of the skin where the thickness is. Now we're not saying that the epidermis and the dermis. We know those are your layers, but some parts have calluses. Say all of our feet. I don't know about your feet, but they got calluses on there. Your knuckles may have calluses. Your palms. So certain parts are going to be thicker than others, and we roll from it there. The skin is more easily damaged than the thick skin. So the thicker the skin, they say the tougher you are, but not all the time. Sometimes they still need hugs with thick skins. All right, so let's go over some of the anatomy. We talked about the epidermis and dermis, but we're going to break it down a little bit deeper, and we'll go over into a diagram in just a second. So if you have any questions, please feel free to talk and or just not gonna hurt my feelings. So the epidermis is the tough external layer that forms a watertight covering for the body. Well, if it's watertight, then how do you sweat through it? Sorry, that's my brain. All right, so the epidermis is composed of several layers. The dermis is the inner layer of the skin, and it contains hair follicles, sweat glands, subcutaneous glands, blood vessels in the dermis provide the skin with nutrients and its oxygen. Bam! I'm sure for the ones that's ever taken A.M.P. in college or y'all have seen this before and had to break it all down. But right here is our layers. Subcutaneous tissue, that's your fat. Right here, that's the base part of your blood vessels coming in and out. Then you have your dermis, and then you have your epidermis, which is your uppermost outer layer. Then you see your hair follicle comes all the way down into your subcutaneous slash dermis area, and how it's connected to the blood vessels. Yeah, because it's got to get its growth. That's how it gets its nutrients. But at the same time, it's still alive and it's still attached. Let's see. That's the sweat gland. That's kind of important. We don't want to block those pores where the sweat can't come out. Like there's one, there's one. So that's a breakdown of everything. All right. So skin covers all the external surfaces of the body. Pretty sure y'all knew that too. The mucous membrane provides a protective barrier against bacterial invasions, just so it can't just get on us and infect us. So bacteria has to enter through an open wound, orifices, or I want to say absorbed, like if it's been blood and it touches us through a cut. So basically, we'll go back to open wound. They secrete a watery substance that lubricates the openings. The mucous membranes do. They're moist, whether the skin is generally dry. That's how you know it stays moist. Um, Physiology: skin serves many functions. It keeps pathogens out, keeps fluids in, helps to regulate the body temperature. The nerves in the skin report to the brain and the environment and many sensations. This nerve pathway connection allows the body to adapt to the environment through response in the skin and surrounding tissues. That's the reason why, like, if you ever notice, normal day, everything's kicking. Oh, you have, let's say, hair on your arm, hair on your legs. You notice how it'll lay in a direction. You're able to, uh, let's say, brush it or move it to a certain direction. But then when you get cold, everything stands up. The hair on your arms, your legs, they stand up, they grow because the skin gets tight. It creates that barrier that it's trying to temperature regulate. That's kind of the path I was going down, even though it took me a minute. All right, so any break in the skin may allow bacteria to enter and increase the possibility of infection. There goes our WBCs. Maybe if y'all remember our white blood count, they'll go up before the infection gets in there. You can lose fluid through there. Obviously, we know the loss of temperature, and any of these conditions can cause serious illness and even death if none of them are treated. Y'all know you can die of hypothermia, so that's not a deal. Fluid loss, you lose too much blood, you're done. And then the infection, if you can't treat it, your white blood cell comes out, you just become septic and you just pooey. You're done. We need to fix that. So, three types of soft tissues injuries. You have your closed, your opened, what is the deadline? It's not on here. I'm gonna have to go back and look into that because I think that's supposed to be 2. So you close it open. So the closures damage occurs beneath the skin or the mucous membrane. Let's say you took a hard, dropped an elbow to somebody's arm. Well, that can create a bruise, so that's a closed injury. An open injury is there's a break in the skin surface or mucous membrane exposed deeper situations to contamination. Okay, that makes sense. I had to reread that. So burns. Damages result from thermal friction, toxic, electrical, and nuclear. You can see all but probably nuclear in your area. Sometimes you'll get like radiation burns from your chemo patients. You'll have a radiation toxicity. Somebody that works at a plant and they forget their meters. But most of the time, those plants do their best to treat their own people first because they have a med staff on board because they are handling a nuclear radiation device. Those are well marked. You're not easily going to get in there. And if it's near the source, you can hang it up. You don't have the clearance to see that. So let's go over some closed and open injuries. So healing of wounds is a natural process that involves several overlapping stages, all directed towards a larger goal of maintaining hemostasis. This sensation of bleeding is the primary concern. Ceasing, sorry. A loss of blood hinders. What is this note saying? Loss of blood hinders the provision of vital nutrients and oxygen to affected area. It also impairs the tissue's ability to eliminate waste. The end result is an abnormal or absent function which interferes with homeostasis. I think we kind of went down and figured that out. The next wound healing stage is inflammation. Kind of get your redness, kind of get your swelling, a little bit of temperature to it. And additional cells move into the damaged area to begin repair. WBCs migrate to the area to combat pathogens that have invaded the exposed tissue. So it's going to fight the ones off in there. It's going to try to be a bully and kill them. Lymphocytes destroy bacteria and other pathogens. Mast cells release the histamine, going to help with the inflammation and the swelling. And inflammation ultimately leads to the removal of a foreign material, damaged cellular parts, and invading microorganisms. So think about this. If you ever had a splinter stuck in your finger, you'll notice that maybe 1 or 2 days later, unless you just happen to see it and it's so big, and then you kind of get like a pus pocket. Well, the pus pocket's from the contaminated parts that inside the body that they weren't able to get out. And then you pop it, push it out, whatever. Well, it becomes inflamed because maybe you didn't clean it real well, and then an infection starts in. So everything that came from that splinter is still in your body. You just got to get rid of it and clean it properly. Let's see here. To replace the area damaged as a soft tissue, a newer layer of skin must be moved to this region. Cells quickly multiply and redevelop across the edges of the wound. Except in cases of clean incisions, the appearance of the reconstructed area seldom returns to the primary state. Despite the changed appearance, the function of an area may be restored to near normal. So they may still be messing around on the inside, trying to get the heel, even though it's healed from, most of the time it's inside out, but it could be deeper on the inside versus small on the outside. And let's say a splinter. So maybe they cut the splinter out. Well, the cut to let the splinter out is going to get inflamed, and then you clean it. So you kind of see where we're going here. So new blood vessels form as the body attempts to bring oxygen and nutrients to the injured tissue, because oxygenated blood helps shapes everything. New capillaries bud from the intact intact capillaries that lie adjacent to the damaged skin. These vessels provide a channel for oxygen and nutrients and serve as a pathway for waste removal. Because we got to get it out of there somehow. Because we know it's happened at the cellular level, just may not be as much as what we're used to, but it's still got to go. In the late stages of wound healing, coagulation provides stability to the damaged tissues and joins wound borders, thereby closing the open tissue. Collagen is tough, fibrous protein wounds, fibrous protein wound and a scar, hair bones and connective tissues. Whew, come back. And collagen cannot restore the damaged tissue to its original strength. So it's just like a broken bone. Sometimes they'll heal faster. I mean, they'll heal back better than stronger. That's fine. But in this case, it's not going to work. I don't know what's up with these Jones. Can anybody else having trouble hear me, or is it just me? I don't know if my new headphones are pretty jam or if they not. Can somebody tell me? Let's see. Stand by, let me.
No, I can hear you pretty good. You're loud and clear.
All right. Well, I don't know why when I start to type, when I go through the class, it does not allow me to type. I don't get that. I mean, I can click on everybody, but I can't type. So if you send me a private message, I'm not ignoring you. I just don't know why I can't do it. So I'm sorry. We're gonna have to talk to him about that. All right. Did we talk about that? I think we talked about that one. I guess that's what I hear. Have issues when I start pushing buttons. Let's see. We talked about this one. New blood vessels. New capillaries blood. We talked about that in the last stage healing. Collagen. We talked about that one. So characteristics of closed injuries. So you have a history of blunt trauma. Pain at the site because it's tender. Now you're going to see the bruising. You'll see the bruising underneath the skin. That may be one. Swelling beneath the skin because the tissue is inflamed. It just got smoked. So it's going to swell. It's going to react to it. It's going to release some of the epi to the area. It's going to try to heal itself, and it's going to move forward. Then you'll obviously the discoloration is going to be your bruise. So you get your bruise going, you get all that stuff situated, and that's what's going to be happening on the closed injury. You can't see them. We already went over that. And those are the more dangerous when it comes down to it because you don't know what's going on. I can only take care of what I see. So a contusion or a bruise is an injury that causes bleeding beneath the skin but does not break the skin. So that's a contusion. Contusion results from blunt force traumas striking the body. Now, don't just think when we say blunt force that I'm smoking you with a baseball bat. You can be walking and hit yourself on the edge of the couch, and that's considered a closed injury. The epidermis remains intact, but cells within the dermis are damaged. Small blood vessels are usually torn. The buildup of blood produces a characteristic blue or black discoloration called ecchymosis. A hematoma is the blood that is collected within the damaged tissue or the body cavity. It occurs when a large blood vessel is damaged and needs and bleeds rapidly. Sorry, my B's and N's. I don't know where that came from. It's usually associated with extensive tissue damage. So, let's see. Everybody likes like torn a muscle, strained a muscle, and you can get that bruising in that area. It takes a hot minute to get back. Robin, you're right. I guess it does sound like I need to take a nap. I don't know why. Like I'm ready to roll, but I'm gonna yawn every time I talk to y'all. So we know what the closed injuries are like because we've all had a bruise. We've all had that somebody walk up and be like, "Oh, does that hurt?" No, jackass, it feels great. Thank you for poking my bruise. Thank you. I will get you back. So y'all know we've all been there. Just want to make sure that y'all understand what we mean by a closed injury and what's actually causing it is our big thing. Uh, Sorry, I'm having kids. Whew. All right, next. So let's talk about this one. A crushing injury occurs when a significant force is applied to the body. The extent of the damage depends on how much force is applied, the amount of time that the force is applied. So think about let's say a vice grip that you use to move something, some tools that's in your tool belt. You put that vice grip on your hand and you lock it in place. And then over time, you just start tightening it and tightening it. After a while, you're going to crush that particular area and make it flat. But if you spontaneously open it right back up, it's going to be okay. It's going to make it. But if you leave it locked down, that's going to be the harder and the more extensive injuries. Um, Continued compression of the soft tissues will cut off circulation, producing further tissue destruction. When an area of the body is trapped for longer than 4 hours, an arterial blood flow is compromised. Crushing syndrome can develop. When a patient's tissues are crushed beyond repair, muscle cells die and release a harmful substance into their surrounding tissues. Harmful substances are released into the body's circulation after the limb is freed and blood is returned to flow because it's starting to die and it's going to kill everything else around it. So the body has this cool way of saying, "Oh, we can't let it go until it's time to, react." Well, depends on where you're located. If you're out in the middle of nowhere, it may take a lot longer. You may lose that area or something else around it. Advanced life support providers should administer IV fluids before the crushing object is lifted off the body. Could be, your core part of your body, an extremity. So it's not just locked down on your core or an extremity. It could be anywhere that this crushing of this injury is affected. I've had one where a loader was loading an 18 wheeler and he pulled forward, not letting the loader be aware. And when he realized that he popped the clutch and rolled right back, well, it ended up pinning the worker between the dock and the truck. It was kind of gross, but you know it is what it is, and it took hours to finally release him, and he ended up passing. But it can happen anywhere. Let's see. Compartment syndrome develops when the edema and swelling results in increased pressure with the closed soft tissue compartment. Pressure increase with the compartment, which interferes with circulation. The delivery of nutrients and oxygen is impaired by products of normal metabolism accumulation. Phew, that's a little deep. There is pain, especially on passive movement. The longer the situation persists, the greater chance for tissue death. EMT must continuously reassess the skin temp, color, and condition along with distal pulses due to the injury site of the crushed injury. So let's say my arm is crushed. You want to check for a you want to catch for a radial pulse and then a brachial pulse, depending upon where the crush is located. If it's further down the arm or up the arm, you may have to go for the armpit where you use the Doppler device and locate it that way. The greater the amount of energy absorbed from the blunt forces is the greater the risk of injury in deeper structures. So the inside, just like a bullet, if it passes through, the shock wave is what causes the problem, and that's just the more force that's rolling down with it. You must assess all patients with closed injuries for more serious hidden injuries. Um, Oh, all of our animals are not being nice to each other. I think it's the weather coming in. So the open injuries. Open injuries differ from closed injuries because it's open and one is closed. You can see in one, you can't see in the other. Found it. We know the answer. If they're open, they're going to potentially bleed a whole lot worse. Bleed, not breathe. They'll bleed completely different. A break in the protective skin layer or the mucous membrane means that the wound is contaminated and may become infected. Wash it, wash it, wash it out as fast as you can. Contamination, the presence of infections or infectious organisms or foreign bodies such as dirt, gravel, metal in the wood. Let's see. Address both excessive bleedings and the contamination in your treatment of open soft tissue wounds. So if you need to stop the bleeding, that's fine, but it's also let's say don't wrap it with the 4x4 on top and there still be dirt in there. If it's bleeding, that's fine, but you still need to control the bleeding once you get there. 4 types of open tissue wounds. You have your abrasions, lacerations, avulsions, and penetrating wounds. So let's dive off into this. So an abrasion is a wound of a superficial layer of the skin caused by friction when a body part rubs, scrapes across, when a part rubs or scrapes across a rough or hard surface. An abrasion usually does not penetrate completely through the dermis, but blood may ooze from the injury of the capillaries in the dermis. You may have road rash, so let's say a road burn, strawberries, or a rug burn. Um, Abrasions can be extremely painful because of the nerve endings are located in this area. So, that's somebody's shoulder. We can probably just say he was riding a bike, slipped, tripped, and fell. Boom, he's done. Oh, where's my bell? I don't know what happened to him, but it was like a boat propeller maybe. A laceration is a jagged cut caused by a sharp object. Um, an incision is a sharp, smooth cut. The depth of the injury, um, it can vary. It depends on how much pressure was applied. What was it? Let's say like a turbine that pulls water through it. Did it happen to pull it and the blades cut? Was this, for example, let's just say that's a boat propeller. You see it's deep up top, and you see some tissue there, and some good meat, and the farther down you go, the less it is. Maybe they realized this boat prop was in the process of turning down, and this person got too close. Who knows? We don't know that. But you can see the break in the skin from the top layer. It's down here at the fatty layers. So um, it all depends on the depth there. Oh, gross. An avulsion separates various layers of tissue, usually between the subcutaneous layer and fascia, so that they become either completely detached or has a flap. So you have a flap of skin. Sometimes you need to pull that flap of skin back so you can clean it out, but you don't want to cause some discomfort. Like this fine fella right here probably needs that to be opened up and squirted through here, and they'll clean that with all normal saline flushes or a bottle of normal saline. It helps out. All right. Often there is no significant bleeding in these open injuries, and never remove an avulsion skin flap. That's just I don't know who would want to do that. That's just gross. Like, sorry sir, I'm gonna pull this off of you, or we're just gonna cut it. You no longer need it. Whoa, whoa, whoa. Don't be that guy. Please don't. All right. So an amputation, we know what that is. We've all at least seen it on TV. I don't know if you've had it or dealt with it or carried part of a limb, finger, or whatever. But whatever caused the amputation, it may be a clean cut, it could be a rough cut, it could be a tear, uh, it could have been a pull. So it can be anything, but that the limb is no longer part of the body. It depends on its condition when it came off, in whatever form it came off. It was, it could be jagged, smooth, and it all that's going to depend on when they go back. When they attempt to put it back on, is it going to be an easy reattachment? Is it going to be a hard one? I don't really know because you got to even make sure it lines up. Maybe you missed some skin that you cut off from the avulsion. That's gross. All right. Um, let's see here. If there's anything important in my notes that you need. If there is massive bleeding, you should stop the bleeding. Duh. Which often requires a tourniquet. And treat the patient for hypovolemic shock. A penetrating wound is an injury resulting from a piercing object such as a knife, ice pick, splinter, or bullet. These objects can damage structures deep within the body and cause unseen bleeding. If the wound is to the chest or abdomen, the injury can cause rapid or fatal bleeding. Remember that one because that's you can't fix it. And impaled objects that penetrate the skin but remain in place. Concerns with this type of injury. You'll have damage to the structures deep inside the body that we just can't see. And maybe we just secured the knife in there in this dude's chest and we're going to roll in and they're like, well, what's it looking like on the inside? Bro, I don't know. That's your job to figure that out. So remember that. And the presence of a foreign material inside the tissue can lead to infection. We got that, Linda. We got it. You don't have to keep telling us. But they tell you that because they want to make sure that you know if you leave stuff behind, one, it's going to look bad if they ever have to go to surgery. But two, is just going to be gross. So clean that out. Get rid of that infection. Take some saline flushes and just flush it galore. If not, you should have at least a normal saline bottle on your truck. Use that. I mean, you got to clean this wound out. Let's see here. Stabbings and shootings. Those are always fun. Assess the patient carefully to identify all the wounds. You may not see them all. Strip and flip, babies. Strip and flip. Count the number of penetrating injuries, especially with a gunshot wound. Leave the distinction between entrances and exits to the physician. In a shooting, determine the type of gun when possible. Do not let this delay the patient transport. Why do y'all think it is important to identify the weapon or the bullet? Vicky, I know you and Mickey gonna answer. Come on now. All right. Oh, look, my wife's paying attention. Y'all, I got you. Oh, come here, honey. I tell them. Well, yeah, it's beneficial. Look, even Vicky said it. So you know the amount of damage. My wife went to EMT school many moons ago, but she refused to take National Registry. So I quietly remind her that she was a pretend basic, but she's pretty good at it. I'll give her that. So yes, so you want to know the amount of the damage. So if you know that you were shot with a 22, which is still as dangerous with a high 45 or 50 caliber bullet, but you know the kinetic energy that is potentially there. That's why we want it there. Um, let's see. Sometimes patients or bystanders can tell you how many rounds were fired. Don't really count on that because they're gonna hear. I just heard all sorts of pops. So just rock on. And you may have to testify in the court. Carefully document the circumstances surrounding the gunshot, injury to the patient's. Oh. Um, and the treatment you give. If you go to remove the shooting victim's clothing, do not contact the box. Do not cut through the bullet holes. Please cut around. I've always tried to tell people when you remove someone's clothing in the reason it needs to be removed in a traumatic issue, cut on the seams unless the injury goes through the seam. But most of the time, the seams are always on the inside of the pants leg or on the outside of the leg. So those kind of help you a little bit easier. Knife length is also very super important. Thank you, Vicky, because that helps us determine. And most of the time, you can always tell if it's a woman or a man that does the stabbing. Women come from the ground up, and men come from the air down. So women like to punch you in the gut, men like to take your head off. That's the way I've always remembered it. Kind of helps you in the long run. Document, document, document. Oh, while I'm speaking on that, in the next couple of days, hang on, we'll see what Victoria says. Also, you need to know if there's any exit wounds. 22 bullets tend to ricochet off bones, cause more damage, and will end up in parts of the body you didn't think. That is correct. I actually am going to try to see if I can share a actual x-ray that I had of a patient that I took care of, that he was shot in the head 3 times with a 22. I have x-rays of it, and it's very, very cool. Statute of limitations is way past it, but it's I got to figure out how to add it to you guys so you can see it. I may try to add it on a break or something, just add it to this picture slideshow. So if you'll notice when we take a break and the screen disappears, that may be what I'm trying to do. Because they are slower ballots. I know what you're trying to say is bullets. I'm picking on you. So 22 still do have a lot of FPS, but ultimately, yes, they are a slow bullet, but they move very quickly. Bigger the bullets, let's say 45, 50, and a handgun, they have a lot of kinetic energy. They will knock your teeth in the dirt, but at the same time as they don't go as far. They have a lot more drop. Um, 9 mil, 40, 45, 40s, I'm sorry, 9, 3, 38, 380, 45, 49. They have a very good FPS, which is foot pounds per square inch, which is great. They do really well, but they do travel far. So that's what they're saying is they know your weapon, but at the same time, you may not have to. You be like, oh, I don't know. They said it was like a 22 long. It doesn't matter to you if you don't know weapons, but that's okay. I mean, just rock on with it and carry on the struggle. So primary blast patients. Blast injuries often occur in multiple penetrating injuries. The mechanism of injury from a blast injury is generally due to 3 factors: primary blast, secondary, and tertiary blast injuries. So we're all going to say is, I'm not going to read your notes. So primary is when that bomb hits, poof, and you get that shockwave. That's your primary. What is flying with it when it explodes? Let's say if I put some washers, ball bearings, or something like that. That right there is going to be part of the primary blast. The secondary blast is from flying debris that may come with it. It can be anything. Tertiary blast is the victim that is thrown by the explosion that they may, if I was standing outside my home and let's say an explosion went off and I got thrown into the house, that is a tertiary blast injury. You can have tertiary cause a penetrating object. You can have a primary blast cause a collapsed lung. So you can have to do decompression. Uh, I've seen it all. I wish I could tell you. Normally, the ones that you see are secondary to tertiary because your initial blast injuries are they're all fatal, but depends on your distance. So keep that in mind too. Let's see. Patient assessment of a closed and open injury. It is more difficult to assess a closed injury than open injury. Well, duh. I mean, we already figured that out because I can see it. If it's closed, I can't see it. Anytime you observe bruising, swelling, or deformity, or the patient is reporting pain to the possibility of a closed injury should be considered. Any opening injury is considered to assess because you can see the injury. So if it's open, you want to put your hands on it, you want to touch it, you want to mess with it. You want to see how it goes. I actually made the mistake last night and yesterday, and I worked during through all the chaos that I have going on at my home. I signed up for a 24-hour ambulance truck. Yes, I know I was retarded, but ran multiple calls in 24 hours. But we did have one where a guy slip, tripped, and fell, and the fire department was there first, taking care of him, good deal. I walk in, don't really, I mean, I'm not going to push you out of the way just because I'm the medic. They had a medic on scene doing a great job assessment. I look at his blood pressure. The initial blood pressure was 257 over 175. I don't know about y'all, but that's pretty damn high. So I sat there and I listened. The medic had him a good assessment, got everything going. I don't believe I refuse to criticize in public. I always praise in public, criticize in private. Get him on the stretcher, get him situated. Well, I noticed I was like, this dude's having some like his blood pressure keeps getting higher and just not so good. Um, I don't like to treat in the home unless it's cardiac arrest. I like to treat in my clinic, my environment, which is my ambulance, and get him out there. Right side deficiencies, didn't have a droop issue, started going on. Well, what happened? Everything happened from a slip, trip, and fail. Closed injury ended up causing him to have a stroke. The hospital didn't believe me at first until they did a scan of him and saw the bleed in his brain. I was like, told you. But, I don't brag like that. That's our nurses. They know it all. So, scene safety. No, this is not it. Y'all can get over it. We're not done yet. Observe the scene, hazards for your crew, bystanders, and patients. Ensure that the scene is safe and considered for the need for additional resources. If I need them, let's call them. Take the necessary standard precautions before approaching the scene. Open soft tissue injuries may be messy, but you should not take the priority over more life serious injuries. Where is my mouth? There it is. And be careful when you put your hands, place your equipment, and how much package the patient for transport and how you package the transport. Focus on controlling the bleeding. Matter of fact, I forgot about this one. 4 o'clock this morning? No, 2:30 this morning. Guy had uncontrollable bleeding from the mouth. I was like, okay. My partner, she just finished EMT advanced school, has not tested out yet, and I was like, "This is your call, girl." Y'all, this guy had 6 teeth removed. I don't know if you know anything about medications. Well, he's elderly and he takes warfarin. Well, warfarin's a blood thinner. Well, this cat started taking his warfarin today like he was told. Y'all, he went through an entire roll of paper towels just trying to control that bleeding on the way to the hospital. And I went, 20, 15 minutes to the transport. So, yeah, and I mean, every time he would put it in there, get it going, it'd clot, and he'd just pour it out and pour it into a throw up bag. It was, oh, I don't do smells, first off, just so y'all know. Smells and Chris Wally don't go hand in hand, they don't work. But focus on the controlling the bleeding. What am I supposed to do when it's in his mouth? So we folded up several tissues. He stuck it in his mouth. He applied pressure. Provided comfort care and checked his vitals, and we went to the hospital. So not all the time you can control the bleeding. So your MOIs, look for your indicators that as you assess the scene. What do I see? What am I, what do I get out of this scene? They can help you develop an early index of the suspicion underlying injuries. Maybe we said this before. Maybe they can. I don't know. The MOI may provide information about potential safety threats. Use available information to evaluate the scene and consider whether additional resources may be necessary. Well, if it's one patient, we're not going to need nobody. We're just going to stick it to ours. We're going to take this patient to the hospital. But if it tells you some of those telltale signs that this guy's you're gonna have some internal bleeding, you're gonna need some ALS care. You're gonna need an IV. You're gonna need an IV O2 monitor. You're gonna need to check him, 4 leads. Do a good assessment. It's not the time to start tapping to see if it's a hollow organ or a solid organ, but you're gonna need to know, like, oh, he's got some rigidity on this side, or he's now tender here, or wow, look, his left lower quadrant is swollen. If you don't do your assessment, you walk in and be like, is his belly always that big? I guess it is, because that's all you can say, because you don't know. Evaluate, evaluate, evaluate. Primary assessments. Look for general impressions. Look for indicators of the patient's condition. Check for more serious hidden injuries. Uh, and check see if they respond. Well, as you're walking up, check on them. Hey, sir, how you doing, ma'am? Can you hear me? If they raise their hand, roll over, whatever else, at least you know they're alert. May not be verbal. That's important. ABCs, or let's just do your A and B. I'm addicted to breathing, y'all. As we've said this before, keep your patient breathing. It's the less paperwork you got to do. I promise. Just keep them on the breathing side on their own, if at all possible. If you happen to see anything that's impaled or stuck in the chest, always do your decap BTLS. Deformities, contusions, abrasions, penetrations, burn, tenderness, laceration, swelling. Don't forget those. 22 years ago, and I remember like it was yesterday, trying to remember all these acronyms. So there is always hope on the other side of the rainbow. Once you get done, you'll get a better idea. But y'all are going to be good. All right. Circulation. Let's make sure they got pulses, PMS, pulse motor sensory, because that's important too. We need to make sure that they got blood going round and round. You need to treat the patient for shock. If you just think that they're having shock, issues, just elevate their feet and go from there. It's okay even if they're not, and you come later down the road. At least you're prepared, and the workload is not so hard on their heart as they're advancing. As you maybe get to the hospital, people are like, "What's she doing? Why is his feet so up?" I'm just trying to keep him from going into shock. Maybe keeping all the blood center to his body. Sometimes people will be like, "Oh, okay," and then maybe they do it from you next time. Primary assessment. You're gonna do transport. Immediate transports. If you have any of those below, those abnormal vital signs. So let's say just because they're not 110/70, like the book says, doesn't mean it's abnormal. What is abnormal for them? Like I picked up another young lady last night. She was probably maybe 95 pounds wet at 30 years old. And when I checked her sugar, it was 251. And I was like, God dang. And if y'all know me, Victoria, you've worked with me before, you know I talk like they talk. I'm like, girl, what is your deal? She's like, what? That's normal for me. Oh. Okay then. So attitude of the customer, man. You got to talk to them so they can understand you. But you want to, what is different for them? Shock, severe pain. There's not much we can do for severe pain as we get out in this world as basics. Need some ALS care. Depends on where you are and what agency you are. Maybe some of your basics can provide some pain management medications, but a lot of states they're not allowing them yet. So just remember that. Those are some of your signs you want to look for on what and making your transport decision. Do I need to transport, intercept ALS? Am I going to be able to transport completely and not need ALS? Or we're going to stay and play? Those are kind of our big things. We're going to go over the next two. Take a break. Investigate the chief of complaint. Ask questions. There's all your mnemonics right there. Use them. Y'all remember those. Your sample, OPQRST, decap BTLS. Remember those questions. Use them so we can make our assessment and our history. Build a great freaking report. Listen to people. You don't know everything as you walk into this room. So let people just talk. As y'all notice, I'm good at that, but I seem like all I do is talk to y'all. I'm gonna need y'all to respond sometimes. No, I'm just kidding. But I would y'all can talk anytime you want. So if the patient's unresponsive, attempt to obtain from the history of others. If there's even anybody around, that's the thing. Let's see if they close to you and move on. Get your questions asked. Typical signs of an open injury: bleeding, breaks in the skin, shock, hemorrhage. Now hang on. So we classify the open of the skin. We're not saying a bone sticking out or something sticking in. It's cut. You've all cut yourself with a knife. That's an open wound. It may not be bleeding right this second, but it's broke. The skin's broken. So disfigurement or loss of a body part. Huh. Now here's the fun part, y'all. If it is no longer on the patient and you can get it, bring it with you because they may be able to reattach that toe or that trigger finger. So make sure that you put them in a bag and bring with you, preferably a plastic one that you can put ice around and go on. Let's see here. Chronic medical conditions such as uh, anemia and hemophilia, as well as a host of other medical conditions, can complicate open soft tissues. Yeah, cause see, they gonna keep on bleeding, and you're gonna be like, oh, they tank's empty shortly. They're gonna run out, but people can bleed for a hot minute. Guys, I got 7 o'clock. I need to move around. As y'all can tell, it sounds like I'm just beat down tired. Maybe I am. I don't know. But we're going to take a quick break, and I will see you guys in 10 minutes. Any questions? Put it on the chat. I'll be back to you in a minute. All right, back at it. Everybody hear me? We good to go? Let me at least hear somebody say we're doing good on hearing. Good. All right, I'll take you, Mickey. All right, moving right along. Secondary assessment. So we know what secondary assessments are. We know that we're looking, it's more of a detailed, focused assessment. Yes, we're going to do a head to toe again, but it's more, I'm going to take time. I'm going to, decap BTLS, the head, the scalp, the nose, the ears, the eyes, the mouth. I'm going to touch it. I'm going to touch it. I want to expose it. I want to be able to see it. I need to know if things are exposed, broken, bruised, there's open anything here. I'll work my way all the way down. And the secondary assessment is what they try to say, which is it includes some interventions and vital signs. That's either 510. But they try to want you to make sure you do your secondary assessment on the way to the ED. Now, if for some odd reason that you're delayed, um, you're not able to run all the way straight to the hospital, it's okay if you stop and you need to do a reassessment, and you may reassess multiple times. Depends on the mechanism of injury, not just a one time and you're done. So your physical examination, I want you to put your ears, and I say your ears, not your physical two ears, put their stethoscope on and listen to your patient. Listen to their breath sounds. Listen to their heart tones. You need to know what they sound like. You need to know what you're going to move. Listen to their respiratory. And as you're there, you can quit breathing, listening to them at certain times, and listen and count their breathing, their respiratory rates. That's a telltale sign when you're that close how the respiratory rate's going. Note the rate and pattern and quality of the effort. Are they struggling to breathe while you've told them, hey, do me a favor, just be quiet, take some slow deep breaths. I'm going to listen to you for a couple of seconds. A couple of seconds for you may literally be a couple of seconds, but you may not move for 10 to 15 seconds or 20 seconds on this patient because you're listening to them. And just look for the chest wall movement. Is there any deformities? Is there any break in any part of it as you're assessing it? You want to know more about your patients on secondary assessment. When you do the neurological exam, check your LOC, which is your level of consciousness. I want you to note pupil size and reactivity. Do they respond by motor? And that means PMS, pulse motor sensors. They have full movement of their wrist, elbows, not their elbows, their wrist and ankles. Can they move in full directions or something limiting them? Assess the musculoskeletal system by performing a detailed exam of the entire body. We talked about that. We're going to do decap BTLS. We're going to do the chest, abdomen, extremities, and for hidden bleeding and injuries, expose it. You got to touch it. If you touch it and you see blood on your hand, now you know where to go back and start to look. Log roll the patient on their side, and that is your time to check the back. Run your hand down the back, looking at your hand every single time to make sure there's no glove and or potential tear on your hand from where you may have got hung up or something that was penetrated into his body. Once you check that spinal cord, you can put them on a backboard or in a Stokes basket, whatever you got situated there. You can move your patient to your stretcher. So check their JVD, jugular vein distension, and make sure that it's straight. I need to make sure that their trachea is right on point and there's no deviation to one side or the other. If you happen to see deviations, you need to really listen to their lungs because there's a reason why it shifted to one side or the other. Check when I say check the pelvis stability, you'd want to do a pelvic rock, but they don't want you to kind of grind it anymore. Like if you, oh, I don't even know how to tell you to do it. It's so hard. I don't even have my little girl. She's asleep. I can do it on her, but be careful when you check that pelvic. Make sure you're having an issue, cautious and not trying to, cause more damage to the pelvic fracture if there is one. Check the abdomen. We know we separate those in 4 quadrants. If they're complaining of the right lower quadrant first, you would start on the left upper quadrant, left lower, and then the right upper. Kind of your way around. Check extremities, core PMS, and their sensory. Have them touch Hey, can you feel this? All right. Can you feel this? Sensory. Do me a favor. Move your fingers around. It's flexing. You're doing, full PMS assessment. Always check your vital signs. Just turn it on, let it go. Do its thing. If you want to interrupt it, push the button. Always check for tachycardia, tapnea, or low blood pressure. All three of those are going to insinuate a sign for you to get ALS assessment, ALS provider there. That way, they can help treat those three things. Look for a weak pulse, cool, most pale skin. Kind of means they're rating it back to a heart conditions. Reassessment of the body. The patient's vital signs will indicate how well the patient is tolerating the injury and the effectiveness of your interventions. If you do in your reassessment, you do secondary assessment, and you note that realigning his head has opened his airway better, you better start writing that down. You need to note upon reassessment, noted tilt chin lift in the beginning and posture, the position that you left him in has increased his breathing. So that's something you did made things better, and you went back and rechecked it. So, like, let's say if I start an IV, I need to periodically check it to make sure it hasn't infiltrated and it's backflowing blood through the IV line. Which I thought I did that yesterday, but it was a blood pressure cuff. I didn't know my partner put it on that arm. Reassessment again. Repeat the primary assessment. Assess the effectiveness of the prior treatments. What you did it work? Do you need to try something else? Do we need to try anything to make it better? Recheck patient interventions. We talked about that. Bandages. Make sure it hasn't bled through, that it is still intact. Things good to go. It hasn't moved. It hasn't adjusted. I want y'all to keep this little wally tail in your pocket anytime y'all work a cardiac arrest. Always, always have a C-collar available for your paramedic. Once they tube them and put a bite tube on there, a bite block on there, and they secure the tube at the teeth, and they memorize that number, to keep it from moving, apply a C-collar on them. The head can move side to side, but going up and down and back and forth is not going to cause that will cause the tube to come out. Side to side is not. So, and it does hold it in place, Victoria. Very good. I was dreaming off in space, and I was like, oh, look, somebody said something. All right. Oh, I'm tired of talking about reassessment. Expose the wounds. If you got it controlled, I don't want you to take the bandages off. Leave it covered. Give some supplemental O2 if you need to. Reassess ABCs. There's your time on your reassessment to flush and clean those wounds out, because now you have time on the way to the facility, the ED, because you've got them situated and taken care of. So now you can do the doctrine that you need to do. Description of the MOI. Pictures, pictures, pictures. If you're able to take a picture of the scene, mechanism injury, the car. Oh my God, the car looks like a can opener now. Take a picture of it. Show it to the ED. Be like, what did you rescue it for? And you didn't have this and this done. Because this is one, bruh. Little things like that help. Whew. All right. Now we're going to talk about closed injuries. We'll do the same thing for closed injuries. Let's see here. A smaller contusion generally requires no special emergency medical care, but you should note their presence to determine the extent of the patient's injuries. More extensive closed injuries may involve significant swelling and bleeding beneath the skin, which could lead to hypovolemic shock. The injuries might not have had time to cause swelling or bruising. Closely watch an area of injury throughout the time you are with them and note any changes, redness, or swelling. Here's some of your things you can use. It's your rice manomet. That word kills me every time. So rice is rest, ice, compression, elevation, and splinting. Be careful. Some places, depending on what part of the country you're in, don't allow you to do a splint with ace bandages. Just FYI. Signs of shock. You can read those 7 right there. If the patient exhibits signs and symptoms of shock, treat that accordingly and aggressively. Don't just goof off and be like, oh, yeah, I'll get to it. We gotta get in the truck with the air conditioning on because it's hot out here. Come on now, let's get that done. I mean, that's important because you're lacking inability to treat somebody may end up causing way more harm, and you can't fix that. So if you notice it, treat it right then and there. And little things you can do is when you put them on the stretcher, just lower the head and elevate the feet. That's automatically you're doing something right there that helps. Before you begin care for the patient with open wound, follow standard precautions. Gloves, gloves. If life-threatening bleeding is observed, assign one team member that you may have to apply direct pressure over the wound to control the bleeding while you get the supplies. Uh, when you're doing your skills, if you don't visibly have somebody else standing there to help you, say at this time I'm going to request at least 2 to 3 more attendants or crew members to help me with this patient, and I'll inform them what to do. So that way it's kind of like playing the old game, ghost man on first, ghost man on second. So that helps you just work, and you have those things that you control. If the wound is in the chest, upper abdomen, the upper back with exclusive dressing, pat it. If it's on their back and they're bleeding profusely, and you put them on their back with the pad, most likely it's gonna clot, unless it's a through and through blood GSW. Control the bleeding, direct pressure. We talked about that. Tourniquet slash resort. Oh, you're gonna like this next one. All open wounds are assumed to be contaminated and present at risk of infection because it's open. We don't the dirty stuff and germs stay on the outside. So anytime it's exposed, you have to automatically assume that it's dirty. Prime example, I told a lady last night. Well, I knew she had a UTI just by her complaint, but I was like, any possibility chance you could be pregnant? No. I said, you still have your ovaries? Yes. I said, well, then there's a possibility you could be pregnant. I said, so in your head, do me a favor and count and see if there's any days that you could possibly be pregnant. And she just looks at me and she's throwing up, I hate you, but yes, there could be. I mean, you got to keep the bad stuff out. Ask these questions you don't know. Control the bleeding. Uh, in most circumstances, hospital personnel rather than EMT will clean up wounds. In some cases, you can better control bleeding from an open soft tissue wound by splinting it correctly, even if there is no fracture. Doom, doom. All right. Somebody want to tell me what that is? Oh, never mind. Without looking. All right. So that is an avulsion, or evisceration. Sorry. Evisceration. This means the organs protrude the body. I've seen this once in my life. Lady had surgery. Left UMC. If y'all know anything about the Jackson area, there's a Wendy's. This is UMC. There's a Wendy's about right here outside the facility. Was in the line, sneezed. She drove her butt right back, and she had this sticking out. We were in the ambulance bay, and she's like, "Hey, I need some help." And we're like, "Oh my God, what is that?" So, seen only one, and I'm okay with not seeing anymore. All right. So, how to cover the wound with a sterile moistened and sterile saline gauze? Because you need to keep these organs clean. You need to keep them moist. I really hate that word. Keeps the organs moist and warm. Most patients with abdominal wounds require immediate transport to a trauma center because they know they gotta have surgery. That's the reason why they gotta go there. An impaled object. And occasionally a patient will have an object such as a knife, fish hook, wood splinter, or pieces of glass impaled in his or her body. To treat the injury, follow the steps on skill drill 26-1. I expect to see all y'all's pictures of y'all doing that. I'm just kidding. So there's only 2 circumstances you can remove an object. I need y'all to make sure y'all pay attention to this. The object is in the cheek or mouth and obstructs the airway. The object is in the chest and directly interferes with CPR. The only 2 times that you can remove that. Other than that, You splint it in place and keep rocking. If the object is very long, you may have to secure it and then even shorten it. We don't have the abilities to shorten a lot of things unless it's by scissors. So you may have to call the fire department out there to come out there and let them figure out how to get this goddamn rod shortened. It's just what it is. At the there is, and just make sure you transport pretty freaking fast, because that is not the best thing in the world. Yeah, fish hooks in some cases. We all dealt with them. We have certain ways. We all like to get them out versus the next guy, but I've seen some in some gnarly places. Whoop. All right, neck injuries. So let's see here. Open neck injuries can be life-threatening. That's because you got your cricoid artery on either side. So it's kind of it's very very important. Tape. Victoria says tape a paper cup over anything impaled in the eye and cover the unaffected eye. So there, you forgot something, but that is correct. At least like if there's a pin, a stick, or style, when you take that cup, poke a hole in the cup so the part of the utensil that's in the eye has room to poke out, which still leaves some room for it with the cup to hold it in place. So those are good ones. They're good to use. Let's see here. Neck injuries. If enough air is sucked into a blood vessel, it can block the flow of blood into the lungs and cause cardiac arrest. It's cause an air embolism. They can, no, I just said that. Cover the wound with occlusive dressing. Apply manual pressure, but do not compress both cricoid arteries at the same time. You will make them pass out. That's that wrestling WWE move. Yeah, you got them. Bites. So small animal bites and rabies. Consider the scene a crew safety prior to entering the environment. A small animal's mouth is heavily contaminated with virulent bacteria. Consider all small animals' bites to be contaminated and potentially infected wounds. Mm, yes, you need to, but I don't. We've all been bit by that. By your own dog and it's broken the skin, or with little bitty puncture wounds from your cat. So just be cautious about that. The treatment may require dismemberment, antibiotics, and a tetanus for sure. Surgical repair if it has to be at the last resort, and a small animal bite should be evaluated by a physician. So no matter what, you're gonna have to take them to the hospital. So you might as well just be like, oh, all right, let's go ahead and get on a stretcher. What hospital are we going to? I don't want to go. Well, you're already in the ambulance. So let's go ahead and take a ride. We're right here. We're not too far. Always do your thing to get them to go. Let's see. A major concern in the spread of rabies is an acute potential fatal viral infection of the central nervous system that can affect all warm-blooded animals. This virus is in the saliva of the rabid or infected animal and is transmitted through biting or licking an opened wound. Infection can be prevented by a series of special vaccine injections. They're very, very, very expensive. Children, particularly young ones, may be seriously injured or even killed by dogs. The animal may turn around and attack you as well. Do not enter the scene until the animal has been secured by the police or an animal control officer. They're going to do what they want. Just stay out. Stay in your truck, lock your doors. Human bites. The human mouth contains an exceptional wide range of bacteria and viruses. Oh, we all know that. These damn masks make it worse. Regard any human bites that penetrated the skin as very serious injury. Any laceration caused by the human tooth can result in a serious spreading infection. That's gross. Oh, all right. So there's a bite. Looks like a little figure eight. Not sure what bit them. There's how to treat it. Apply dry, sterile dressing. Promptly immobilize the area with a splint. Probably wouldn't do that. I'd just cover it. Take them to the ED. Burns. Okay, so burns kind of get me. I like burns. Burns are fun. Y'all hope you got something to write down because I'm sure we're gonna go over the rule of nines and the percents and all the fun stuff, the fitnesses. All right, so burns account for approximately 3,400 deaths per year. Burns are among the most serious and painful to the injuries. A burn occurs when the body or the body part receives more radiant energy than it can absorb, resulting in injury. We got that. Some potential sources: heat, toxic chemicals, electricity. That's just dabbing the surface. Although a burn may be the patient's most obvious injury, you should always perform a complete assessment to determine whether other serious injuries are present. Children. I'm sure there's a story behind that one. So children and older patients and patients with chronic illnesses are more likely to experience shock because there's not a lot left. They got thin skin. They've got not a lot of viscosity in their blood, and their skin is woe out and learning how to do it. JW, burns are not awful when it's yourself. I had 9% of my whole body, but oh, bro, I'm sorry to hear that. I hate that. I had a third-degree burns to my face years and years ago. They cut, scraped, and all that fun stuff, and I'm still ugly, but I can't get it to work sometimes. Just don't cover it up. Burns are soft tissue injuries that can spread over a larger area and are created by the transfer of radiation, thermal, or electrical energy. So y'all think about those different sources that we talked about. Thermal burns can occur when the skin is exposed to temperatures of 111 or higher. As y'all know, in Mississippi, we can see those. In South Louisiana, you can see that on a fun day. I remember one morning I was doing a PT test in Iraq. We had to run at 3 a.m. because the sun rose at 4, and by 7 o'clock, it was already in the hundreds. So, Victoria, I meant she loves the burn chapter. Years ago when we were in physics class, she failed the burn chapter big time. Oh, I'll see her grade before she will. So, it's all right. Um, Patho of burns. The severity of thermal burns correlates directly with, we read those, the temperature, concentration, amount of heat, we know, and the duration. Um, the longer they're there, the more thickness and more areas going to be burned. A lot of times they'll go into shock, and it probably depends on the thickness and situation. They may not wake up. Could be also due to a respiratory issue that they maybe inhaled a lot of smoke, so now the duration of the exposure to the steam, to the fire, is just unsped into the heat, and unfortunately, they're not going to make it. Patho of burns. Uh, let's see. People relatively limit heat and energy time exposure time. They cannot do so if they're unconscious or trapped. He normally doesn't. Um, Heat hurts. Burns hurt. I can promise you. So, if the clothing is on fire, the person that's trapped, unconscious, or exposed, time can be limited. That's that final layer of protectant, of any protectant, and if it's on fire and are gone, it's a serious situation. Let's see. The skin serves as a barrier between the environment and the body. We know that because it helps regulate temperature. When a person is burned, that barrier is destroyed. Burns create a high risk of infection, hypothermia, hypovolemia, and shock. So we can fix some of those, but trying to fix that in the field is what's going to be so hard because we may or may not have the ability to use certain things because it depends on your agency or what your med control for that area is like. Some agencies will allow you to fix that right there in the field. Apply, thermal blankets, creams, stuff like that. Some agencies just want you to, pour a high flow of diesel to the motor and get going. Burns to the airway are significantly important because the loose mucosa and the hypopharynx can swell and lead to a complete airway obstruction, meaning they done. Circumferential burns to the chest can compromise breathing because now it's tight. It's just like leather. When leather dries out, it becomes very tough. That's where your skin is around your chest. Let's see. Circumferential burns to an extremity can lead to compartment syndrome. We have, I'm pretty sure, a picture of that in a minute, resulting in a neurovascular compromise and irreversible damage if not properly treated right. So they may have to do a cut down. That's what they're trying to get to. Oh, let's see. Burns, you want to know depth, extent, and critical areas. The critical areas are those 6 that are right there. Face, upper airway, I can't count, so it's 5. Face, upper airway, hands, feet, and genitalia. Pre-existing medical conditions or other injuries are important. Let's say they have COPD. So if they have a facial burn, now they may be extremely hard to intubate. So you have to think about that. Am I going to be able to intubate this person that has now been burned and they're a COPD patient? Geez, is this what's going to be next? Is this what I got looking forward to? So those things are some of the things you need to keep in mind is what kind of injuries does this person previously already have that can affect me anymore? We talked about this earlier. Patients younger than 5 and older than 55 will compress completely different than your normal middle-aged patient because they're going to compensate super, super fast. Here's our depth. We're going to get superficial, partial, and full. Here, let's just look at that. So, superficial right here. See the redness around there. Partial thickness, you'll have the pus areas, the water sacs, and then the full thickness or the 3rd degree. That is really bad. So then you come down here. This is what a 1st degree looks like. Partial thickness, you can see the blisters. They're around here, and then a full thickness. That's so old. Look at that mask. Woo! That's a simple face mask. That's old. But kind of gives you an idea of what you're going to see. It looks like this guy potentially fell on something. You see that line right there. Not knowing what it is, not really that I care, but that's what that looks like to me, or something was thrown on him. This poor soldier right here with his arm looking that way could be from an electrical burn. I don't know what else could be chemical, but the reason why I asked is I say the electrical is because the skin right here looks like it's already starting to peel. See it over here, and that's the quittiness in this. It's going to turn into muscle, so kind of sucks. Still burns. Let's see. All right, so this one's going to take me a minute. Rule of palm estimates the surface area that has been burned by comparing it to the size of the patient's palm, which is roughly equal to 1% of the patient's total bodily surface. Rule of nines estimates the extent of a burn by dividing the body into sections, each representing approximately 9% of the total body surfaces. The proportions differ for infants. When you calculate the extent of a burn, include only partial and full thickness burns. Document superficial burns, but do not include them in the body surface area estimate of an extended burn. Whew. Look for entry and exit. Yeah, that's right, JW. So electricity is going to find the path of least resistance, and if you think that it's an electrical burn, it may have gone in the hand, the head, look through the feet, it's the soles of each feet, and they may have blown it out that way. So here's some of the burns. This is the rule of nines. So the front and the back are 18. Genitalia is 1. We talked about that. And if you noticed here, 18 on the head, 12 on the kid, and 9 because we go front and back. Because their children's heads are 18 because they're so much bigger. Their chest in the 18, that kind of sticks with us all the way around. It's hard for a toddler or the middle picture because each leg's the 16.5. And when you're trying to multiply in your head and trying to get that crap going as fast as you can, it will mess you up. I promise you. 2 seconds. Let me look at something. All right. Let's see here. When assessing a burn, it is important to classify the patient's burn. I want you to classify it as source of the burn, deep of the burn, or severity of the burn. Oh, sorry, something in my eye. That's what I need y'all to classify and learn to classify those as. Oh, here we go again. To safety, make sure everything is safe for you to go in, that you're not going to get injured on the way in. You have mechanism of injuries. I need to know what type of burn that has been there and all that has been sustained. Attempt to determine the type of burn that has been sustained and the MOI. What the patient reports will often provide important information about the extent of the injury. Assess the scene for any environmental hazards. Call for additional resources if needed. And call for the potential spinal injury, broken bones, inhalation, and other injury. Um, you want to make sure that you just don't rule that out. It's the first thing you see is what you're going to smell, but don't forget about the others. This one's going to get your attention, but this just may be the first wave of injury that you find as you go through your assessment. Mechanism injuries, assess scene for the environmental hazards, determine number of patients, call for additional resources. Always begin with a rapid general impression, prove that as you're walking up to them. You want to check for AFPU, airway and breathing. Ensure that the patient has a clear and patent airway and it's maintained on their own. Not saying if it's maintained separately that you don't need to keep that medical device on them, because that is true. You need to, all the way to the hospital. Be alert to the signs that the patient has inhaled hot gases, singed facial hair, nose hairs, soot present in and around the airway. You may see like a person wipe their hands on their face, and that's like, oh, well, there's soot. Well, no, let's ask questions. You know, were you in the fire? No, I was a fireman around here, and I touched something. So keep your eyes open for that. Heavy amounts of secretions and frequency. Cough may include a respiratory bun. Quickly assess for adequate breathing. If they're not, just give them some oxygen. Let them have their issues. Always check circulation. Determine perfusion based on their patient's skin color, temp, and cap refills. Control other significant bleeding. Assess for shock. Transport. Are we gonna go in a hurry? Are we gonna stay and wait? I don't know. Each one of them is gonna be different. Each call that you go to on a burn, the severity is gonna be completely different. But go with transport decision. Stick with it. Right on. If you need to get ALS en route, that's okay. We know it's okay to move on and get some help. We all hope. History taken. Get as much as you can. Yeah, there's some pain, redness, swelling, blisters, and charring are all signs of burns. Then document that. Document. If you don't and you don't put it in your report, but you try to testify about it, it's not in there. You didn't do it. Back on that. Soon to be coming, you will have a module that you guys must do on your own. It'll be different a night. I'll post it in. You'll have to take a test on it. It's strictly on documentation. And then, ding, 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 starting later in the class, everyone will be responsible for providing a PCR, patient care report, prior to being out there on your own or getting out to start doing rides. I want you to do reports. and you're going to send them to me. I will give you your patient info, and you will write me a report. I'm going to have fun reading those. All right. So investigate the chief complaint. What is happening right now? If it's still burning, stop it. Don't continue. If you can get their ring off, get it off. They're having burns, the hands, the jewelry. Get those jewelries off as fast as they are, because the heat is going to transfer between them. Always treat them for shock, because during a burn, they're going to decompensate pretty quick because they lost that thermoregulator. Here we are again. Maybe they took some burns to the face, to the airway, having difficulty breathing, swallowing. Are you having any pain? Maybe it's burned it all the way down to the core, and they're like, "Ah, that looks really bad, but it don't really hurt." And you're just like, "What would you say?" So ask questions. There we go again with your physical exam. Keep your decap, BTLS. Got me there. Just simple words. Package your patient transport. Remember, if you're going to be transporting a burn patient, you don't want the air set on 65. Even though it feels amazing because you're working your butt off in the back of the truck, you need to set it where it's comfortable for the patient and that they're not shivering. They can hold their body, because they're going to have a long road ahead of them, and you want to make it as comfortable as possible that they don't go into shock. Physical exams, we went over this earlier. It's the same thing. Same thing. All right, emergency care. Stop the burning process. Prevent additional injuries. Thermal burns. Okay, we got some time. So thermal burns are caused by heat. Most commonly, they are caused by scalds or open flames. A flame burn is very often a deep burn, especially if a person's clothing catches fire. A scald burn is commonly seen in children and the handicapped adults, but can happen to anybody, particularly while cooking or bathing. Hot liquids produce scald injuries. Scald burns often cover large surfaces of areas, and because liquids can spread even quickly, you splash somebody with something, it's going to run just to more places, just in the center of the chest. Whoa, sorry, my wife's throwing stuff at me. Come in contact with hot objects. Produces a contact burn. Contact burns are rarely deep unless the patient was prevented from drawing away from it. So if something fell on them, they're not going to be able to move. It's going to be there. Or let's say they had a heart attack and fell on it, and they weren't able to move. So it is pretty deep, because it came in contact and you're unable to pull away. So you can also get a thermal burn through a steam, scald, lightning strikes can cause thermal flash burns. Tell you what, let's take a break. I'll see you back at 8 o'clock. I need to take care of something real quick. All right, sorry about that. I kind of got tied up. So go back over here. All right. So inhalation burn. So anytime that you see a potential inhalation burn, look for soot around the nose, around the mouth. That's going to show you your. That's going to be your visual signs that something has caused an upper airway burn. So those burns are critical, and when you see those, you need to respond and act quickly and accordingly because they're potentially going to shut down super fast. And once they start shutting down, you're not going to be able to request ALS assistance for fast enough, and you're not going to be able to get an ET tube down, King airway, even a bougie for a paramedic. You're not going to be able to get these things down because they're starting to swell. That soft tissue is swollen because it's taking damage. Um, so when you're treating a patient for inhalation injuries, you may encounter severe upper airway swelling, which requires immediate intervention. Um, Call ALS backup if you notice stridor, hoarse voice, singed nasal hairs, burns to the face, or carbon particulates in the sputum. Kind of everything I was just telling you. I didn't know it was on this slide. Apply cool mist, aerosol therapy, or humidified oxygen to help reduce some minor edema. So hopefully you can try to keep some of the swelling, but it ain't gonna happen. The combustion process produces a variety of toxic gases. The less efficient the combustion process, the more toxic the gases may be created. So, man, when it comes to inhalation, you gotta act quickly, and you definitely have to transport on the quick. Carbon monoxide intoxication should be considered whenever a group of people in the same place all report headaches or nausea. Cherry red skin, lips, and nail beds are commonly observed in patients who have died from carbon exposure. Do not rule out CO exposure simply because the patient's skin is not cherry red. HCN, which is hydrogen cyanide, is generated by combustion. Signs and symptoms involve the central nervous, respiratory, and cardiovascular systems. You will see faintness, anxiety, abnormal vital signs, headache, seizures, paralysis, and even a coma. Management of your inhalation burns. You must first ensure your own safety and then the safety of your coworkers, which we know that just falls back to scene safety. So if you recognize the signs and symptoms of potential CO exposure, you want to make sure you have a SCBA tank, a self-contained breathing apparatus, basically is what that is. Firefighters go in there and remove them. Don't run in there and try to hold your breath because you probably won't make it. Some inhalations. Pre-hospital treatment of the patient with suspected HO, hydrogen cyanide, includes decon. They're going to need to be washed off. Supportive care until an antidote can be administered. You want to recognize it, identify, and give supportive treatment. And this can occur whenever toxic substances come in contact with the body. They each of these chemicals react differently to everything. The chemical may not react to your skin, but it may react to the raincoat that you're wearing out of the blue, just happens out of the blue, and then now that jacket is now being burned to your arm because there's a chemical exchange. The eyes are obviously particularly vulnerable because there's really not much there to protect them. They're always open. We're looking for things. It's generally caused by strong acids and strong alkalis. So let's see, chlorine's the biggest one. We have a lot of chlorine burns in pools, chlorine in pool boys. Pool girls also get the same issues from being burned like that. Severity of the burns. You want to know what type of chemical, what is the concentration, and how long was the exposure. To prevent exposure to hazardous materials, determine if you can safely approach the patient. Hang on, sorry. If you can safely approach them, or you must wait until hazmat. So if you can't get to them correctly and a timely manner, and because it's safe, you may need to call for some extra help. Wear appropriate chemical resistant gloves, sometimes latex and or whatever your normal day-to-day gloves are is not appropriate for that. So you're going to have to look at the MSDS for this particular sheet, and you may have to wear something completely different. All right, some chemical burns. Treatment for chemical burns can be specific to the chemical agent, like we said. Management of chemical burns. The severity of the burn will depend on the type of chemical, its strength, duration of the exposure, and the area of the body exposed. To stop the burning process, remove any chemical from the patient. Always brush dry the chemicals off the skin and clothing before flushing the patient with water. Because if it is reactant to water, at least you're trying to get, oh, where's my cursor? You're trying to get all this big stuff off before you kind of wash it off. I mean, this may actually be reactant to water, but we're going to try to brush it off and at least try to get it to look like this before we start to wash the skin off. And it still may have a small irritant, but that's what we're trying to prevent from all that area now being burnt. Remove the patient's clothing, including shoes, socks, gloves, and jewelry, and or eyeglasses. Some of your management. Let's see here. Take care to ensure you do not come in contact with the chemical. The patient should be properly decontaminated by properly trained personnel. For liquid chemicals, immediately begin to flush the burned area with a large amount of water. Continue flooding the area with gallons of water for 15 to 20 minutes. After the patient says the burning has stopped, if the patient's eye has been burned, hold the eyelid open without applying pressure over the globe of the eye while flooding the eye with a stream of water. Let's see. As with any substance, once the fluid has been contaminated with the chemical, collect it and properly dispose of it. I don't know how many times I've ever seen that. They just washed it up on the floor. Conduct a proper decon prior to loading the patient and into the ambulance, and again prior to entering the hospital. You're just trying to reduce the contamination. It's really what they want you to do. What you get contaminated with, you leave on scene. Electrical burns may result in contact with high or low voltage, and sometimes the low ones can be worse than the bigger ones. It seems like this slide's completely out of order here. Ordinary households current can cause severe burns and cardiac arrhythmias. For electricity to flow, there must be a complete circuit between the electrical source and the ground. We know that because sometimes the switches don't work. The human body is a great conductor because we're full of water. Electrical burns occur when the body or part of it completes a circuit. So let's say it's kind of like, if you hold your friend, you make a circle and you shock everybody at once, basically what you're looking for. Let's see. The type of electrical current, magnitude, or current and voltage have effects of the seriousness of a burn. I don't know much about electricity at all, except it hurts really bad. You can be fatally injured by coming in contact with a power line, which we all know that. Never attempt to remove someone from an electrical source unless you are specifically trained to do so. Always assume that any downed power line is alive. I think we've all been taught that since we were children, but that's something we need to continue to remember. Even after a big storm, don't go out and touch any metal fences because there may be one that's a couple hundred yards away, but that's activated that line and you not know it because you can't see it. Let's see. A burn injury appears where the electrical enters and exits the body. So, like JW said on here, look for the entry and exit burn on electrical burns because they're going to follow the path of least resistance. So, it could be hand to foot, hand to hand, shoulder to foot. So it could be everywhere. If the patient is not in cardiac arrest on your arrival, he or she is unlikely to experience the problem during transportation. I don't know what this picture is, but that's gross. I think that's from a burn. The illustration on the show damage that an electrical burn can cause. That's okay. That's gross. Defibrillate if you have to. If they go into cardiac arrest, always give them supplemental oxygen. Treat soft tissue injuries with dry sterile dressing, and provide the quick transport. Just give them that bolus of gasoline and get them to the hospital. Tasers are not as serious as everybody thinks they are. They're not going to cause a burn, or you may see some burns from when the probes hit you, but ultimately, it's not gonna. I mean, you may die from falling and hitting your head on something, but the electrical current that it produces is not. It will give you cardiac dysrhythmias. Sometimes they say if you get that dysrhythmia or you have an underlying heart disease and you get hit by that ride, that you might go into cardiac arrest. I'm not gonna say it's not possible, but many years I haven't seen it. There are potential complications for the patient with these devices have been used, particularly when the patient experiences certain underlying disorders like we talked about. Next one. So radiation burns. So an acute radiation exposure has become more than theoretical issues because the use of radioactive materials has increased in the industry and the medicine. Potential threats include incidents related to the use and transportation of radioactive isotopes and intentionally released radioactive into terrorist attacks. But we've all heard that where they use radiation. There's all different alpha, beta, gamma types of radiation. They can use some. I just went blank. What else they use? But they'll set them off into the explosion, and that's what activates it and aerolizes it. It can burn you. It can kill you. It can do all sorts of stuff. So you must determine if it's been a radiation exposure or whether it's ongoing and continuous exposure. So we talked about the alpha, beta, and gamma. There you are right there on those screens. Alpha will stop by the skin, which those we see every single day. Beta, you're probably going to need a protective clothing, blocked by simple clothing. Gamma, that is, it easily passes through body. The only thing that's really going to stop that is like a fire truck. It's got the metal, 1,000 gallons of water, and metal again, and then you on the other side. So gamma is very hard to stop. Most of your hospitals have very, very thick walls when they do these radiation treatments or radiation, even x-rays, because of the massive amount of it. On radiation burns, maintain safe distance. You need to make sure they're clean, and I mean clean is that they're not carrying radiation when you go to transport them. You're going to know that by contacting some other authorities. Most contaminants can be removed by simply removing the patient's clothing, but you're still going to call for other assistance when you go for that. If they have some open wounds, try to wash it out in case some of the radiological particulates get stuck into those blue jeans. Let's see. Once there is no threat, you begin to treat the ABCs and treat the patient for any burns or trauma. Gotta make sure the threat's gone before we can take care of them. Let's see here. Notify the ED as soon as you know that there's a radioactive source and the length of the patient's exposure. Remember that you need to calculate by the time that from the time that they started the exposure to the time it was stopped, the time the symptoms started, and your transportation time, how long it's going to take you. They may tell you you're going to have to go to this location. Because, I mean, most of these hospitals don't want radiation patient coming in like that. They're not denying to treat them, but they're going to have to treat them in a different particular area that's safer. Limit your duration of the exposure, increase the distance from your source, and attempt to place a shield between yourself and the source of the gamma radiation. Fire truck. Get behind the fire truck. Y'all know some of these bleedings, all these up here. You know what each one of those are. I'm just not going to sit here and harp on that. That is not fun for me. We know what dressings are. We're going to cover the wounds. We're going to make sure things are covered. I love 4x4s, 2x2s. Those are kind of your best ones. 4x8s are a little bit bigger. You'll get some of your ABD pads in the 4x8. Some of them will have self-adhering, some of them will come out in rolls. Y'all know that. We've all checked off manifest, been on around it long enough. Steel dressings, gauze pads are appropriately for smaller wounds. Sometimes it may take 10 or 12 of them. Doesn't really matter. Got to control the bleeding. I mean, if that's what you got to do, you got to cover them up, keep them covered, and open that whole entire box in the back of that truck. Occlusive dressings prevent air and liquid from entering or exiting the wound. So let's keep that nasty stuff, and they can keep it. I don't want it either. We know they come in roller, gauze, triangular bandages, adhesive tapes. I'm not gonna sit here and bore y'all with this because I would hope that all of y'all know how to do some type of bandaging to keep from blood leaking out. Okay, splints are useful, stabilizing a broken extremity, and can be used with dressings to help control bleeding in soft tissues. We talked about this. Cardboard splints, you may have some of your metal rigid splints. So those are kind of your main sources. All right, we're going to talk about this right here. We're going to do the a review real quick. I'm going to let y'all review test question number 1, and then I'm going to let y'all have a night. A young male was struck in the forearm with a baseball and complains of pain to the area. Slight swelling and ecchymosis are present. You note external bleeding. What type of injury does this describe? Should be 12 answers on the board. And 11 more. All right, so we're going to have a little challenge here. So, not everybody's entered, but that doesn't ever happen. So, why do y'all believe that it's either a contusion or a hematoma? Tell me why. That's your chance to talk. It's going to help us get through this. All right, folks, I am unmuting y'all on my end. So that is a hint for y'all to unmute your mics and let's talk about this. Somebody, I'm going to start picking on y'all. Tell me what a hematoma is.
It technically could be both.
Tell me.
You can hear me, Chris?
Yeah, I hear you. You good?
It depends on, I mean, he was struck in the forearm with baseball. Was it from a batter? Did somebody throw the ball at him? Or was he just in the way?
So,
I mean, it could be a hematoma, which is just a bruise, or it could be a contusion that caused more damage that eventually is going to be just a hematoma.
Mom, mute yourself. I'm about to talk.
all right. So
Sorry about the beeping. I'm cooking.
remember, the few of you that have taken this class before, National Registry will only give you what you see right there, making you're going a little deep. I'm not going to deny your thought process, but you're going a little deep into it. You're wondering what if. So think about that when you go to take National Registry. Read it for what it says. Okay. So let's go back over this. So a hematoma is blood that is collected when drainage tissue or in a body cavity associated with a large blood vessel damage. So there is no bleeding. It just says slight swelling and ecchymosis are present.
Okay, so contusion is, it happens after a trauma, like a blow to the body. It occurs when small veins and capillaries under the skin break. A hematoma is a large pooling of blood, like if somebody were to hit you, if like say a sledgehammer and cause more damage. So a contusion is not as bad as a hematoma.
Correct. So it says, here's the rationale. A contusion bruise is caused by the direct blunt force, like she just said. The epidermis remains intact, but small blood vessels in the dermis are injured. The depth of the injury varies depending on the amount of energy absorbed. Pain and swelling occur as fluid and blood leak into the damaged area. The buildup of blood produces a characteristic of blue and black discoloration called ecchymosis. So that was your keyword, was the ecchymosis. So your answer is B. I will give you guys the benefit of the doubt on what going with C. It was a good one. I'll give you that. So I'll give you a good fight for the battle. Does anyone have any questions, concerns, problems? I really don't want to hear your fusses because I got plenty of myself right now. But what do y'all have any complaints right now? Do y'all have any issues that y'all want to address about this chapter? Any questions? And as you guys know, you have 5 days from tonight or your test expires. You will not get it. Please read your email on what to do if you're missing something. If you are 10 days late, you will automatically have points deducted from your test. So I don't wish that on nobody. I hate that we having to get to this, but I gotta get you guys ready for registry. I gotta get you guys some accountability and get you guys situated because I feel that all of y'all are gonna go towards the EMT A class, and I highly encourage that. And I'm gonna tell you, our wonderful instructor for advanced, she don't put up with it. She does a lot different, and we all teach very different, and I love it. So it's great. It helps us all out. I'm gonna take it since y'all are all quiet. Everybody muted their mics again. That y'all don't want to talk to me no more, and y'all tired of hearing me. So I'm gonna give you your test and class code. Please write this down. Take a picture, screenshot it, memorize it, tattoo it, whatever you want to do. That is how you must type it in, the 8Y59 @ symbol. Can somebody please type it in the code for me in the text box? Obviously, since I can't type there, I need y'all to write it just like that. 8Y59 @ symbol. That is your code that will get you captain letters. Capital letters? Yes, it is all capital letters. So that's how you're going to take your test. And that's how y'all going to get credit for class tonight. All right, folks, if y'all need me, if anybody wants to know about their grades or anything else, please let me know, and I can give you a average. And if you're missing any test, y'all have a good evening. I'm going to mute it. I'll be on here for a little bit longer. And other than that, y'all let me know if y'all need anything. Thank y'all. Great night. Hey, JW, so I have gone in there and double checked every single one to make sure that the codes are good. That's the only way that I can hold it accountable is by adding a code to the test for everybody. But if there's an issue, please message me tonight, tomorrow, and I will look at it again. But I've got to add some type of code and it may just be to where I need to do numbers, and that's fine. I can go back and do that. But JW is the best I can do right now. To the ones that have privately messaged me, for some reason I cannot respond to you guys. If you will, well, please just shoot me a yes. If you're past 2 weeks, I will not. You'll have to follow the rules on how to get the test opened back up to you. But to the two that message me privately, please send me. You can send me an email or a Facebook message, and I'll respond to you about answering your questions. New test the classes. ZW, I'm not following what you're asking then. Oh, I'm with you. I'm sorry. I apologize. My brain's a little slow tonight. Yeah. So I don't know the answer to that. That is, no, I don't know. If you have issues, like I said, just message me, and I'll get you in. I'll get you taken care of and get you to take your test. Maybe it's just you. I'm just picking at you, bro. It ain't.